Dr. Tawfiq.
Start, Doctor.
Good evening, ladies and gentlemen, colleagues. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers, as usual, from Dubai, UAE, GCC countries, and all countries across the globe, especially India and Chandigarh. This webinar is CME accredited in collaboration with NMC Specialty Hospital Al Nahda Dubai and is sponsored by Vita Biotics, new country head, UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali. Well, today we have an eminent speaker, well-known internationally, Professor Surjit Singh from PGI Chandigarh. In a short while, I'll be introducing him and our panelists. Well, as usual, we have a question. So, those who answer, the first answer, Dr. Tawfiq will announce as a winner. You just tell us who is this gentleman and what is his contribution. Beautiful Dubai, as usual, the best time of year to come and see this beautiful city. Don't miss. Those who have not seen, please come. Well, members of Dubai Pediatric Club on 9th annual conference, you see here our speaker, Professor Surjit Singh, who was our guest speaker. Well, the members of the organizing executive committee, myself, Dr. Rajendra Joshi, the past president, Dr. Kalpana Sengupta, secretary of the club, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Muhammad Amir Toleimat, Dr. Ayman Jundi, Dr. Rafia Obara, Dr. Srinivas Bandari, the honorary member, Dr. Leila Al-Bahri, and Dr. Khaled Rashid, very well known to all of you. Well, as I said today, a webinar is about autoinflammatory diseases, a new concept. Our speaker is Professor Surjit Singh, professor and head Department of Pediatric Allergy and Immunology and Rheumatology, Advanced Pediatric Center, PGI Chandigarh. Of course, in a short while, I will introduce him more. He doesn't need introduction. Our panelists are Dr. Kalpana Sengupta, Senior Consultant Pediatrician and Head of Department of Pediatrics at NMC Specialty Hospital, Dubai, and Dr. Diari Muhammad, Chairman of the Academic Affairs and Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai. Well, I would like to take this opportunity. Please join me in congratulating Dr. Kalpana Sengupta, the Pediatrician of the Year award. Here she is getting her award from His Excellency Sheikh Nahyan in a special ceremony in Dubai. So congratulations, Dr. Kalpana. Well, we have our annual pediatric conference, 10th annual DPC conference on 19th and 28th April, means Friday and Saturday, at Maroj Swiss Hotel Rotana, Maroj Hotel, Swiss Hotel at Dubai. It will be 2 days conference. Please note 2 days physical conference. We will have another webinar online later on. So we will have more than 80 faculty members. Please note 80 faculty members in this conference, which will cover all topics in pediatrics. Well, we hope, inshallah, in future to have our annual conferences in a Sky Hotel. Dr. Tawfiq has promised, inshallah. Well, here you see Dr. Tawfiq, the country business manager of the Vita Biotic, receiving felicitation from our chief guest, Dr. Ajit Singh. You are seeing here the founder of the Dubai Pediatric Club, Dr. Let Kuhi. Well, I will give just in 5 minutes a brief history of autoinflammatory diseases. Always I start with Hippocrates, the father of medicine, a beautiful painting by Robert Thom. And one of his most important quotation, first do no harm. But about autoinflammatory diseases, as I said, are a relatively new branch of medicine. Please note, new branch of medicine. The first specific genetic variation, that is Mediterranean fever, that causes familial Mediterranean fever, was identified in 1997. However, please note, symptoms of familial Mediterranean fever had been previously described as far back as 1949, and the disease was known then as Siegel-Catton-Mammut syndrome. A complete description that first utilized the term periodic disease was also given in 1949 by Hobart Rehman. Well, a doctor, a New York City allergist, Dr. Shepard Siegel, first described the attacks of peritonitis in 1945, way back in 1945. He termed this benign paroxysmal peritonitis, as disease course was essentially benign. And Dr. Hobart Rehman, working at the American University in Beirut, Lebanon, described a more complete picture, which he termed periodic disease. We were fortunate enough to have Dr. Rehman in Iran in 1959 to 1961, was professor of internal medicine there. Well, French physicians Henri Mamou and Roger Catton described the complete disease with renal complications in 1952. Well, now this familial Mediterranean female has various names, including familial paroxysmal polyserositis, periodic peritonitis, recurrent polyserositis, benign paroxysmal peritonitis, periodic disease or periodic fever, Rehman periodic disease or Rehman syndrome, Siegel-Catton-Mammut disease, and Wolf pediatric disease, just the names. Well, at the end of 1990s, 2 other diseases with recurrent periodic fevers had been identified. That was hyperimmunoglobulin D and tumor necrosis factor receptor associated periodic syndrome. Now remember these names. In 1999, Michael McDermott and Daniel Kastner introduced the term autoinflammation. Michael McDermott is a student of Dr. Dan Kastner. He is known as Dan Kastner better. Since he was the first author, his name comes first. Otherwise, the Dr. Kastner is a pioneer. Well, Dr. Daniel Kastner, better known as Dan Kastner, is an American physician and researcher specializing in genetics of autoimmune disorders, which made havoc in this field. He is scientific director of the National Human Genome Research Institute at National Institute of Health, USA. Just briefly, I will say, he joined as a fellow in rheumatology in 1985 at NIH. He saw an Armenian patient who has symptoms of familial Mediterranean fever. From there, he got interest in genetics and followed, then he became the director. And he was awarded in 2021 Crawford Prize for polyarthritis for this pioneering work in autoinflammatory disease. Now, who is this Crawford? In Sweden, there was one industrialist who suffered from polyarthritis. In 1982, he kept a prize for polyarthritis and bioscience and geoscience, and since then it is given. The prize is that this award is compared with Nobel Prize, and a prize is given by Swedish Academy. It is the Swedish Academy of Medical Sciences and King of the Swedish king gives the award, very prestigious, and it accounts for $700,000. And Dan Kastner is often called the father of autoinflammatory diseases. Please note, he is the father of autoinflammatory diseases, a title that thoroughly deserved. Well, this is a student, Michael McDermott. Actually, he published in 1999 in Cell journal. His name was first. And if you see here, Dan Kastner was the last. Of course, he also published autoinflammatory diseases with Ivana. That is, Ivana Asketevich. These two scientists also, they are pioneers in this field. Just remember them. Well, Dr. Sujit will tell us about these autoinflammatory diseases, just to mention that autoinflammatory diseases include but are not limited to more than 30 genes have been recognized. CRIA, CAPS, FCAS, HIGHS, MWS, NOMID, especially neonatologists. All neonatologists pay attention, neonatal onset, multisystemic inflammatory diseases. PFAPA, PAPA, ROSA, VAXes, these are all the new diseases everybody should know. Dr. Sujit will tell us. Well, our hero, Professor Sujit Singh, well known to all internationally. Just briefly, he is very well known to all. Professor Sujit Singh is head Department of Pediatrics and Chief Allergy Immunology Unit, Advanced Pediatric Center, Postgraduate Institute of Medical Education and Research, Chandigarh, India. Well, I would like to mention here that PGI is one of the biggest and most prestigious institutes not only in India, but in Asia, and I can say in the world. 277 acres area, very big center. He's the Dean of Research at PGI. He's the head of the World Health Organization Collaborating Center for Education, Research, and Training in Pediatric Immunology. He's president, Asia Pacific Society of Immunodeficiencies. His collaborator, Center of Excellence in Rheumatology, Asia Pacific League of Association of Rheumatology. And his principal investigator, Indian Council of Medical Research, Center for Advanced Research in Primary Immunodeficiencies. He has worked in Kawasaki. He was the president of Kawasaki Association, many others. So I end a beautiful painting, but look, felt this, and a quotation by Hippocrates. He said, life is short and the craft long, opportunity fleeting, experimentation perilous, and judgment difficult. Well, beautiful Dubai. Once again, I would like to invite those who have not seen, please join us now. And here, now I would like to request Professor Sujit Singh to start his talk, and I would like to request all viewers to write their question and answer in the Q&A box. After Dr. Sujit Singh talked, our moderators, they will start Q&A. Professor Sujit Singh, please.
Thank you, Dr. Sohrab. So today we will be discussing this topic of autoinflammatory disorders. This is a very complex set of conditions, and these are conditions about which the total world experience is of something like 25 years or so. And it was not until maybe the end of the last decade that awareness about these disorders really increased, and most rheumatologists began to diagnose and then treat these conditions. These are not very uncommon, and in any rheumatology clinic, especially pediatric rheumatology clinic, you are likely to have a fair sprinkling of these disorders. but diagnosis can sometimes be complex. And for most of these disorders, diagnosis has to be based on genetic tests. So what I shall do is give a broad overview of these conditions and try and point out important clinical clues by which we can diagnose these disorders. How did we get exposed to them? Well, this was a patient whom we saw in the year 2013. This was an 11 years old girl. She had been running fever for several months. She had had recurrent severe abdominal pain for 3 years. And for many of these episodes, she had had to be hospitalized. So this was obviously very significant abdominal pain. On one occasion, the pain was so severe that someone thought of appendicitis and she was operated, but there was no appendicitis on table. Then she developed left eye vision loss. So she obviously had multi-system involvement. We saw this child, and because of the multi-system involvement and the severe abdominal pain, she was also found to be hypertensive. We thought we were dealing with polyarthritis nodosa. So we did CT angiography, that was normal. Then we did digital subtraction angiography, and that showed microaneurysms typical of polyarthritis nodosa. So at that time, we thought we had made the diagnosis. So we treated her for polyarthritis nodosa with standard therapy, that is pulse cyclophosphamide, and followed by oral azathioprine. This is a standard treatment for polyarthritis nodosa. She improved significantly, and we maintained her on oral azathioprine. 5 years later, her brother was brought to our hospital. He was 17 years old, and he had acute painless loss of vision in left eye. So the parents immediately realized that this child may also have her sister's illness. So they immediately brought the child to us. And when we saw the child, we were really in a fix. How come both brother and sister from the same family have visual problems? And it was too much of a coincidence that both had such serious illnesses. This child had a pale retina, which was obviously very abnormal. But what was the diagnosis? Could he also have polyarthritis nodosa? But polyarthritis nodosa does not occur in families. We knew that. So we did some literature search. Our fellows started working on these two patients. And ultimately, we realized that what this family had was DADA2. That means deficiency of adenosine deaminase 2 enzyme. So we got the DADA2 assay done, courtesy Dr. Michael Hirschfield at the Duke University. And what you can see is that the index patient, that is a sister, and the brother had very low levels. And the parents, they had much higher levels because they were heterozygotes. So this was our first exposure to a diagnosed case of DADA2. We got the mutations worked out, and we realized that both siblings were homozygous and the parents were heterozygous for this mutation. So we revise the diagnosis from polyarthritis nodosa to deficiency of adenosine deaminase 2, that is DADA2, which is an autoinflammatory disorder. And it is now known that many children with polyarthritis nodosa, especially when the disease starts very early on in life, are nothing but DADA2. So the treatment had to be revised, and from azathioprine, we had to shift these children to adalimumab. So this shows that if you make a correct diagnosis, you can do a lot for the family, and the treatment will obviously also change. As Dr. Sohrab mentioned, these disorders have been known to medicine only for around 24 or 25 years. And it was Dr. Dan Kastner who first gave the concept of autoinflammatory disorders in 1999. Till around 2005, it was thought that these are extremely rare conditions and one would encounter one such disorder maybe once in your lifetime. But as more and more disorders started getting diagnosed, we soon realized that in most rheumatology clinics, you would have a wide spectrum of patients with these conditions. The first few uh, autoinflammatory disorders whose genetic causes could be worked out were familial Mediterranean fever, FMF, and TRAPS, which is TNF receptor associated periodic syndrome. So what is so special about these disorders? These arise from defects of innate immune system, not the acquired immunity. These are defects of the innate immune system. And because they are defects of innate immune system, they can start very early in life, usually in the first few months of life itself. Neutrophils are the effector cells, not lymphocytes. Unlike autoimmune disorders, lymphocytes are not involved in the pathogenesis of autoinflammatory conditions. These disorders are characterized by recurrent episodes of exuberant inflammation. Patients with these disorders do not have autoantibodies and autoreactive T cells. So, unlike autoimmune disorders, autoantibodies are singularly absent in patients with autoinflammatory disorders. How does one differentiate between autoimmune and autoinflammatory disorders? So, by autoimmune disorders, you have disorders like systemic lupus erythematosus. So age at presentation of autoimmune disorders is usually above 1 year, while many autoinflammatory disorders may start below 1 year. It is very unusual for an autoimmune disorder to present below 1 year. Most autoimmune disorders are much more common in females, while autoinflammatory disorders, they are as common in males as females. Fever and rash usually are not very prominent symptoms in autoimmunity, while these are usually the most significant symptoms in patients with autoinflammatory disorders. Circulating antibodies are usually present in autoimmune disorders and absent in autoinflammatory disorders. Patients with autoimmune disorders have genital linkages to MHC1 and 2 alleles, while these are unusual in autoinflammatory disorders. And inhibition of IL-1 is usually not effective in autoimmune disorders, while a significant number of autoinflammatory disorders benefit from IL-1 inhibitors. Why do we need to know about these disorders? Because early recognition in childhood avoids unnecessary drugs and sometimes even surgery. And early recognition prevents long-term complications like amyloidosis. Molecular diagnosis is now available for the vast majority of autoinflammatory disorders, and effective treatment is also now available for several conditions. Delays in diagnosis result in significant morbidity, but unfortunately, delays in diagnosis of these conditions are rather common. So, from the clinical perspective, I have divided these conditions into 7 groups, and we shall discuss each of these conditions separately. So the most common autoimmune disorder is supposed to be PFAPA, which I have kept separately. It's usually a benign condition. Then we have disorders that have periodic fevers as the predominant presentation. Then fever and rash as the prominent presentation. Some disorders have only rash. Fever is not that common. Some disorders have pus formation as the predominant disorder, the Papa syndrome, which Dr. Sorab mentioned. In some disorders, you have prominent bony deformities. These include DIRA and Majid syndrome. And then, of course, you have granulomatous lesions seen in disorders like Blau syndrome. So this is a very simplified version of a clinical approach to patients with autoinflammatory disorders. So the most common is the PFAPA syndrome, which I'm sure most of us would have encountered in our day-to-day clinical practice, but it is just that sometimes we don't give these children a label of PFAPA. These children develop fever of not very high grade, 39 to 40, which lasts for 3 to 4 days and then settles down on its own. The associated symptoms include sore throat, oral ulcers, cervical adenopathy, loss of appetite, irritability, and myalgia oblique arthralgia. The periodicity is so typical that most parents can virtually point out to the day that X number of days are over and now is the time for my child to develop fever again. PFAPA generally has no rash and no gastrointestinal complaints. It is said to be the most common periodic fever syndrome. Onset is usually from 2 to 5 years, said to be more common in boys. And the clinical clue is that the affected children do not look unwell, uh, uh, even when they have some symptoms. And in between symptoms, they are completely well. At Chandigarh, we have the mean age of onset of around 3.5 years, but the delays in diagnosis were significant. And in many children, the diagnosis was made several years after the onset of symptoms. Once you identify this condition, the diagnosis is virtually clinical. What you have to do is give a short duration prednisolone at the onset of fever, just 1 or 2 days, and maybe just 1 or 2 doses, and it does the trick. The fever comes down dramatically. There are studies to show that tonsillectomy may benefit some of these patients. If the symptoms are very troublesome, one could consider doing elective tonsillectomy because that decreases the recurrence of symptoms. So the second group of disorders are the ones where we have recurrent fever as the predominant manifestation. And most of the pediatricians who work in the Gulf would have come across children with familial Mediterranean fever, which is not that common in the Indian subcontinent. Then we have TRAPS and MVKD and hyper IgD syndromes. So familial Mediterranean fever, which we do not see very commonly in India, this is supposed to be the prototypic periodic fever syndrome. It is autosomal recessive. Patients may present with recurrent fever, pleuritis, peritonitis, synovitis, rash, and myalgia. And because of the heterogeneity of um, the symptoms, it can sometimes be a very difficult condition to diagnose. But serositis is rather typical of familial Mediterranean fever. But fever and serositis, you may be inclined towards thinking of an infective condition if you do not take the history properly. But if you get the typical periodicity with serositis, recurrent fever, diagnosis is generally easy. The major risk of misdiagnosis and delays in diagnosis is development of amyloidosis. Once you diagnose this condition, it responds well to colchicine, and in children who do not tolerate colchicine or in whom colchicine is not very effective, you can also try anakinra. So this was one of our few patients with uh, FMF that we have seen. This child had recurrent fever since early infancy, rash, colicky abdominal pain, which was very severe at times. And this child had had multiple admissions in several hospitals. And for each of these admissions, empirically, she used to be given antimicrobials for indications that were not very clear. She always had polymorphonuclear leukocytosis and thrombocytosis as well. ESR was high. So this child was started on colchicine and improved significantly. This was another child who presented with recurrent episodes of fever. And again, the periodicity was such that the mother could virtually time the onset of fever. She had been investigated at several hospitals, but no cause of the fever could be found out. All infective causes had been ruled out on several occasions. So when we took the history, she had had fever since early childhood, but this fever was also associated with rash, myalgias, and arthralgias. Polymorphonuclear leukocytosis was rather prominent. She had a raised sedimentation rate, a high CRP, and since nothing seemed to work, the parents had got into the habit of self-medication. They would empirically give 10 milligram prednisolone and the fever would come down. So ultimately, based on her presentation, a suspicion of TRAPS was made, and this was amongst the first few patients uh, in whom TRAPS was diagnosed at our center. We got the mutation worked out at Dr. Marco Gattono's lab at Genoa in Italy. So once this diagnosis was confirmed, we realized that there was significant family history as well. The father's brother and his daughter in Canada also had similar symptoms. So when this girl's diagnosis was made, we sent the reports to their doctors in Canada, and their investigations were done, and they were also diagnosed to have TRAPS. So all the affected family members have been started on etanercept. This child has emigrated to Canada and is now asymptomatic. So therapy in TRAPS is based on the anti-TNF agents, and there have been several successful prospective trials using etanercept. And during the acute attacks, you can also use high-dose corticosteroids. The next group of disorders are the cryopyrin-associated periodic syndromes, in whom we have fever and rash. And in this, we have disorders like NOMID and SINCA. So this was again one of our first few patients with NOMID, whom we had not diagnosed when this child had first presented to us. We were not aware of this condition at that time, and we thought that she had some unusual deforming arthritis. But it was much later that the prominent patellae were noted and the correct diagnosis was made. But by this time, this child already had developed amyloidosis. So we treated this child with thalidomide because biologics were not available at that time. And on thalidomide, she was symptomatically better. At follow-up at the age of 19 years, this child had significant deformity and is short in stature. This was another patient, 8 years old girl, in whom again we have NLRP3 mutation. She presented with what looked like steroid-resistant nephrotic syndrome, but there was no history of fever and rash. And when the biopsy was done, she already had developed amyloidosis, and she had a mutation in NLRP3. This child ultimately could not be uh, uh, saved. She died. So what are the treatment options available? We can use the IL-1 antagonist. Anakinra is the one that is easily available in many countries, including in India. Anakinra has now become available in our country and is also available in government hospitals through a government scheme for children with rare disorders. Canakinumab we have never used, and it's much more expensive as compared to anakinra. And this treatment was pioneered by the work of Rafila Goldbach-Mansky, and she showed that if you use IL-1 antagonists in these disorders, you can have significant improvement in the symptoms. If you use thalidomide alone, you have significant symptomatic improvement in as much as you have resolution of fever, rash, and the amyloidosis may also improve to some extent. We have not had any experience with this group of disorders, Muckle-Wells syndrome and familial cold autoinflammatory syndrome. So I will not talk about this, but I will go on to the fifth set of disorders in which you have pus formation. So this is the Papa syndrome, pyogenic arthritis, pyoderma gangrenosum, and acne. So this was a 5-year-old girl who had been symptomatic for the last 2.5 years. So she presented with an oral ulcer over the left cheek and rapid progression over the next 2 days. She had had history of recurrent diarrhea and colitis, recurrent oral ulcerations, for which she had sought many consultations and had even been admitted in several hospitals, given several courses of empiric antimicrobials. She had anemia, neutrophilic leukocytosis, and elevated sedimentation rate, but she had had no response to antitubercular therapy, oral prednisolone, or azathioprine. All these drugs had been used empirically. So this is how she looked when we first saw her. A very scary looking ulceration over the cheek, over the elbow. So even at first look, you can make out that this is something unusual. This definitely cannot be tuberculosis. So Papa syndrome, the other presentations can be inflammatory bowel disease, and it can come also in the differential diagnosis of inflammatory bowel disease. If you diagnose this condition early, you can treat them with TNF-alpha inhibitors and IL-1 antagonists like anakinra. The response is often dramatic. The next group of disorders are the one that have predominant bone disorders. So in this, we have disorders like DIRA and Majeed syndrome. So this was our first exposure to the condition called DIRA. This was a neonate who was referred to us with a diagnosis of osteomyelitis. A 3 weeks old neonate in whom a diagnosis of osteomyelitis was made because this child had lytic lesions over the bones. This child was not moving the limbs. So the treating neonatologist thought that this is infective osteomyelitis, but this was unlikely because both parents were doctors. It was a normal delivery. There was no setting for neonatal sepsis. This was a normal delivery with no adverse perinatal factors. So why should a normal child develop infective osteomyelitis? So when we first saw the child, this child was not moving her limbs. We got a bone scan done and we found that there were hot spots in several long bones. So there was increased uptake in both hips, shoulders, sternoclavicular joints, lower lips near the costochondral junction, and the left elbow joint. Amongst these joints, I must point out that sternoclavicular joints usually are a pointer to something unusual happening. This is a joint which is not often involved in rheumatological conditions in children. So whenever there is involvement of the sternoclavicular joint, this is usually a red flag to the rheumatologist that something sinister is present. And in this child, the sternoclavicular joints were very, very hot. So we knew that we were dealing with something very unusual, but at that time, we did not know what exactly it was. So a literature search was done by our fellows, and we, we thought that this could be consistent with this condition, which is called deficiency of IL-1 receptor antagonist DIRA. But since this was the first time that we encountered such a patient, we were not sure. We took the help of Dr. Refila Goldbach-Mansky at the National Institutes of Health, and this is what she said. If infectious osteomyelitis has been ruled out, the radiographic features are quite consistent with DIRA in the context of elevated acute phase reactants and a high granulocyte count. So this was her opinion, and ultimately she worked out the mutation of this patient, and this child turned out to have a large novel deletion in chromosome 2, and this mutation previously had not been identified in the Indian subcontinent. And both parents were heterozygous for the same mutation. So this was the first time that this mutation was worked out in a patient from the Indian subcontinent. This child was ultimately written up, and the case report was published in the Journal of Clinical Immunology. And this was our first exposure to this set of disorders called DIRA. Since that time, we have had a couple more patients with this condition. Fortunately for us, Dr. Refila arranged anakinra for this patient through the NIH, and this child has been taking anakinra since the time of diagnosis, and this is how she looks at the age of 5 years. Which just goes on to show that if you diagnose these conditions, if you treat these disorders, there is a lot that you can do. You may say that treatment is very expensive. Yes, treatment is undoubtedly very expensive, but there are several opportunities available now in countries like India. Under the National Rare Diseases Policy, children with these disorders can now get free treatment with anakinra in India. So this is something which has happened over the last 1.5 to 2 years, and several of our patients with autoinflammatory disorders would now be able to access treatment with drugs like, 'anakinra'. 'anakinra'. 'anakinra' 'anakinra' 'anakinra'. 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 The last group of disorders that I would be discussing would be the ones that have granulomatous lesions, and in this we have Blau syndrome, and this is also the group in which we have the maximum clinical experience. So Blau syndrome is basically nothing but early onset sarcoidosis. It is a granulomatous disorder, and it usually has autosomal dominant inheritance. The triad of Blau consists of rash, arthritis, and uveitis. But the problem with the diagnosis is that all three may not present at the same time. So one of our oldest patients with Blau presented with arthritis when she was around 3 to 4 years old. She had no evidence of uveitis, no evidence of rash. So this was thought to be polyarticular arthritis at that time. She was started on methotrexate. She remained well for several years, then developed uveitis. So although it is a triad, Blau's is a triad, all these three components may not be seen at the same time. It is characterized by a gain of function mutation in the NOD2 gene. It presents in early childhood, and as I said, the triad consists of a rash, arthritis, which is usually large joint polyarthritis, and what is typical of Blau's is the so-called boggy synovitis. So this is a very descriptive term, and if you see children with Blau's, you would realize that this is a very apt description. The synovitis is really boggy, and then they may develop uveitis, which may either precede the onset of arthritis, accompany arthritis, or in some cases follow arthritis. So this is an affected mother and daughter pair. So both of them, this is the mother's hand, you can see the boggy swelling. This is what is referred to as a boggy swelling here. In no other condition do you get this kind of synovitis, boggy synovitis. And an experienced rheumatologist may be able to suspect Blau's based on this boggy synovitis. So mother and child having boggy synovitis virtually clinches the diagnosis, and this is what is Blau's because the inheritance is autosomal dominant. This was another parent-child combination. This father, when he was a small child, he had received treatment in our institute for what was diagnosed to be very troublesome uveitis. So he had received several courses of methotrexate and other immunosuppressants for the uveitis, but the complete diagnosis could not be made. Later, he developed boggy synovitis. And for this, he sought treatment from the rheumatologist and he was started on methotrexate. His son also presented with arthritis and uveitis. So father-son combination, autosomal dominant inheritance, this is what typical Blau's looks like. So the mutation was worked out, and this was the mutation that was present in this child. And Dr. Rajni Kumra, who is a postdoc in our department, she has been working on patients with Blau's at our center, and she has developed one hotspot. She has identified one hotspot in children with Blau's whom we have been following up. So this is part of Dr. Rajni Kumra's work, and these are some of our first few patients with Blau syndrome. And as you can make out, not every one of them has the typical triad. And in some children, they still have only arthritis. Uveitis is either very mild or not diagnosed. some patients, the uveitis was so mild that it called healed on its own. So treatment of blouse is again with TNF-alpha inhibitors, adalimumab, but you would also have to use methotrexate and steroids, and methotrexate especially is required for the arthritis. So this is a very simplified approach, clinical approach to patients with autoinflammatory disorders. If you keep these 7 categories in mind, if you take the history, do the physical examination, and most importantly, if you analyze the symptoms properly, you would be able to pick up some of these conditions or suspect some of these conditions clinically. But diagnosis would almost always require genetic confirmation, because for these conditions, the treatment is often lifelong, treatment is expensive. So before you embark on such therapy, genetic diagnosis is mandatory. In addition to this, to these more well-identified disorders, you have several miscellaneous conditions which you would see maybe once in a while. So this was a 10-year-old girl coming from central India. She had recurrent episodes of swelling, rash, bloody diarrhea. She had grade 2 clubbing, thereby signifying that this was a very chronic condition. She had forced facies, diffuse erythematous rash. So when we saw the patient, we thought we were dealing with lupus. We really did not know what we were uh, uh, doing with. To make things worse, she had a borderline anti-nuclear factor positivity, but she had had uh, a large number of systems that had been involved, and she had had many hospitalizations. So this is how she looked like, a very odd looking rash. This was an erythematous maculopapular rash. She had coarsening of the facies, and it was only by genetic diagnosis that we came to this conclusion. And because this was the time when we had started doing genetic diagnosis for some of our difficult patients. Um, uh, so this was some years ago. So this was the diagnosis in this child. It was caused by mutation in PLCG2 gene. So these are kinds of patients whom you would see maybe once in a lifetime. But if you make the diagnosis, you can counsel the parents and then advise them what to do, because many of these patients may respond to treatment with anakinra. Unfortunately, this child, she died after a few years. This was a 9 years old child who had had contractures of joints of upper as well as lower limbs. So this cannot be the usual polyarthritis, this juvenile idiopathic arthritis, because all joints were so symmetrically involved. He also had involvement of both temporomandibular joints with very prominent retronathia and very prominent cough. When we took the history on HRCT, this child had interstitial lung disease. When we took the history, we realized that the father also had had similar complaints. He too had been unwell since birth, and this child had a 2 years old brother who also started developing involvement of the symmetrical involvement of the joints. So this is obviously not simple juvenile idiopathic arthritis. So this is the father of the index patient, again showing the arthritis, deforming arthritis, and the father also had interstitial lung disease. So the diagnosis was made by genetic sequencing, and this was our first patient of COPA syndrome. So this is a publication related to COPA syndrome from our center. Then we had this patient again with deforming arthritis, and this was SING-associated vasculopathy with onset in infancy, Savi syndrome. So these are disorders that you would encounter maybe once in uh, uh, 10, 15 years. This was a ship of 3 sisters, all of whom had deforming arthritis and fever. So they had been given a label of systemic JIA, but why should systemic JIA affect more than one child in a family? So here again, the involvement was rather symmetric, and there was polyarthritis and there was fever. But the most suspicious thing was that all 3 sisters having the same symptoms. So this was obviously some kind of a genetic disorder. And after mutation analysis, we realized that this was LAC1 gene mutation in 3 sisters. And without this, you will not be able to come to a diagnosis. So this was a child who had recurrent fever, oral and genital ulcer, ocular inflammation, arthritis, multi-system involvement, does not fit into any of the known rheumatological disorders. So by this time, our threshold for getting genetic tests uh, had come down significantly, and we got the genetic analysis done, and this was haploinsufficiency of A20. DADA2 clinical presentation. I started my talk with a patient of DADA2, but this is one condition where the clinical presentation can be very heterogeneous. One of the commonest presentations is with thrombosis, arterial or venous thrombosis, and several patients who have neurological strokes, in fact, may be having DADA2. It is one of the commonest causes of thrombosis in children. And if you have unexplained thrombosis, whether there is neurological thrombus involvement, GI involvement, DADA2 has to be ruled out. Some of these children may present with bowel gangrene. Some children may have odd hematological involvement like neutropenia or aplastic anemia. Some children can have lymphopenia and peculiar immunodeficiencies. Some children may present with livedoid rash and cutaneous vasculitis, which if you don't do DADA2, you may think this is idiopathic cutaneous vasculitis. So I think we don't really understand this condition completely. The clinical presentations can be very heterogeneous, and they can present to several specialities. So you have to have a very low threshold for working up for DADA2. There is a group of rheumatologists now who are convinced that systemic JIA is also perhaps an autoinflammatory disorder. The reason is that the clinical presentation is very much like autoinflammatory disorders with high spiking fever accompanying rash, hepatosplenomegaly, adenopathy, joint involvement, and the fact that it is not more common in females. So all these are features which suggest that we know that systemic JIA is very different from other types of JIA, but now there are people who believe that this is also an autoinflammatory disorder. And as pediatricians, we must remember that in a patient with systemic JIA, if there is sudden deterioration in the clinical status, high-grade spiking fever, suddenly enlarging spleen, or a child with systemic GIA develops icterus or bleeding. So these are all red flag signs which should never ever be missed. Even a delay of 12 to 24 hours can be fatal if you develop these symptoms and you miss the diagnosis. So this is a presentation of macrophage activation syndrome, which is a very well-known complication of systemic GIA, and no pediatrician should ever miss the emergence of macrophage activation syndrome. If you suspect this, you would get several clues from the laboratory tests. There would be neutropenia, thrombocytopenia, or a fall in platelet count, there would be emerging anemia, raised CRP, and a falling ESR. This is very ominous. Raised CRP and a falling ESR. There would be abnormalities in the PT and PTTK tests, raised transaminases, triglycerides, and raised ferritin. All patients may not have all findings, but if a combination of some of these findings is there, this makes the diagnosis of macrophage activation syndrome very likely. And once you think of it, you have to treat. If you do a marrow, you may be able to document hemophagocytosis as well. But even in absence of hemophagocytosis, if you have some of these laboratory tests that are positive, you should not wait, but start treatment, because delays in starting treatment can be fatal. So in such a patient, you would almost always start with uh, uh, intravenous pulse methylprednisolone. So this is a publication from our center on the spectrum of systemic autoinflammatory diseases. This was a multicentric experience published in Frontiers in Immunology, having data from several centers in the country. And Dr. Deepti and Dr. Amit, uh, they, they are the ones who have major interest in these disorders at our center. So this is the spread of autoinflammatory disorders at various centers in the country, and it just shows that awareness about these conditions is now going up, and many pediatricians, many rheumatologists are now suspecting these disorders, diagnosing them, and over the last 2 years or so, it is now possible for us to even treat them, because as I said earlier, anakinra and other biologics like adalimumab are now being provided free of cost by the government under the National Rare Disease Policy. So some of the common autoinflammatory disorders that we reported in this series, one is Blau syndrome, other is P-FAPA syndrome, then others were hyper IgD, DADA2, but DADA2 I'm sure is a gross underestimate. We must be missing many presentations of DADA2 from other specialities. If you combine all of these conditions, maybe DADA2 would be as common as P-FAPA syndrome. So this is a publication again from our unit on P-FAPA syndrome, our experience. Blau syndrome, Dr. Rajni, who has been working on the mutation in these patients, she has reported Blau syndrome, several aspects of this condition. This is a publication DADA2. This is a single center experience. So autoinflammatory disorders, to summarize, are disorders of the innate immune system. These should be considered if there is recurrent or periodic fever. The periodicity is very typical, and after a few episodes of these fevers, the mother can virtually point out that today is day 21, it is time for my child to develop fever. It is that significant sometimes. They also have joint involvement, which is liable to be misdiagnosed as juvenile idiopathic arthritis. They may have a rash, they may have uveitis, they may have serositis, which is liable to be misdiagnosed as infective serositis. But whenever a child has multi-system involvement and it doesn't fit into the pigeonhole of a common pediatric disorder, think of autoinflammatory conditions, because we have to diagnose them early, and the diagnosis is almost always based on genetic tests. Family history is often suggestive, because some of these conditions like CRAPS, they are autosomal dominant. COPA syndrome is autosomal dominant. Others, like familial Mediterranean fever, are autosomal recessive. Then look at the clinical features. In PFAPA, you have the characteristic periodicity. You can virtually time it, and they respond beautifully to steroids, just one dose of low dose steroids. In TRAPS, they have periodic fever since early infancy. NOMID and DIRA, onset of fever and rash in infancy. Blau syndrome, you have granulomatous uveitis and arthritis with typical boggy swelling. So these are clinical pointers which help you think of these disorders. But the most important clinical pointer is here, which is when there is multi-system involvement and the disorder that doesn't seem to fit into any of the usual rheumatological disorders, think of the autoinflammatory disorders. Several treatment options are now available, even in developing countries. So TNF alpha inhibitors in India, we have biosimilars available for adalimumab, and the cost has come down significantly. Anakinra is now available at several centers in our country. Colchicine and steroids, of course, are easily available. So to conclude, I must say that although we have tried to differentiate between autoimmunity and autoinflammation, this distinction may not always be absolute. In some patients, there may be some features of autoimmunity also in patients with autoinflammation. For instance, it is known that patients with familial Mediterranean fever have increased prevalence of many rheumatological diseases for reasons that are not clear. Some inflammatory diseases have features of both autoimmunity and autoinflammation, and amongst these, I would keep systemic JIA, although it is thought to be predominantly autoinflammatory disorders, but it does not have all the features of autoinflammatory disorders. As pediatricians, we must remember that in children with fever, we must think before starting empiric antimicrobials. We must remember that antimicrobials are not antipyretics. Before you start antimicrobials, at least in our minds, we must have a clinical diagnosis. What are we treating this child for? In children with fever of long duration, we must think hard and seek more consultations before starting empiric anti-tubercular therapy. ATT should only be started if you are convinced that there is evidence of tuberculosis. Empiric anti-tubercular therapy should by and large be avoided. Anti-tubercular therapy should only be started if there is reasonable objective evidence of tuberculosis. I remember that when we were first introduced to clinical medicine in third year at the Maulana Azad Medical College, we used to be taught by uh, Professor S.P. Pamra, and he used to say that treat tuberculosis only if you can document acid-fast bacilli. Although this was meant for adult TB, but the logic was very clear that unless you can document acid-fast bacilli, don't treat tuberculosis. In children, AFB may not always be easy to identify, but we must have reasonable objective evidence of tuberculosis before you start anti-tubercular therapy. Most of our patients with autoinflammatory disorders, if you go back to the history, they have received empiric treatment with anti-tubercular drugs, and this treatment is often not only delays the diagnosis, but also further complicates the clinical course. So before I conclude, I must thank all the consultants in our unit, my clinical colleagues, and our laboratory colleagues. I would especially like to thank our laboratory colleagues Professor Amit Rawat, who heads the laboratory, Dr. Manpreet Dhaliwal and Dr. Sanya Sharma, who are both assistant professors and who worked with Dr. Amit. And it is because of these three laboratory colleagues that we are able to do many of these tests in our own laboratory in the Advanced Pediatric Center, and that makes it so much more difficult. So most of these tests can now be done uh, in our unit within our laboratory, and this includes some of the genetic tests. We can do both Sanger sequencing as well as next generation sequencing. So this is a big help, and it facilitates early diagnosis, and also it facilitates the training of our resident staff. I must acknowledge all the DM fellows who train with us, the PhD students, and the postdoctoral students who work with us. Uh, the autoinflammatory disorders, as I said, we have been diagnosing them only for the last maybe 10 years or so. And we have been very fortunate to have been mentored and guided by our colleagues across the world who have helped us in the early diagnosis of some of these conditions. And these include Dr. Dan Kastner, Dr. Refila Goldbeck-Mansky, who not only diagnosed one of our patients with the first patient with DIRA, but also arranged for free anakinra for that patient. Dr. Isabel Mates, Dr. Michael Hirschfield, uh, who has been involved in our patients with DADA2, and Dr. Marco Gottono, who helped us in the diagnosis of our first few patients with genetic diagnosis of our first few patients with autoinflammatory conditions. So these collaborations are essential because most of these conditions you would not get to see very often, and it is always wise to consult people who have much more experience in managing these conditions. And I must say that all five of them have been very liberal with not only their time, but also their resources. Thank you very much.
Thank you very much, Dr. Surjit Singh. This was an excellent eye-opener talk. They used to say, if mind doesn't know, I cannot see. But now mine started knowing, and from tomorrow I will start seeing these cases and suspect and follow. Thank you very much. Now I'd like to request our moderators, Dr. Kalpana Sengupta and Dr. Diari, to join. Till they prepare the question, one point I would like to mention for our viewers. Dr. Surjit mentioned 4 centers, PGI, Gaslini, NIH, and Duke University. I would like to bring the attention of our viewers that PGI Chandigarh is the biggest institute in India with largest number of DM activities. It is 277 acres, if I am not mistaken, not only based in India, but in Asia and beyond. Gaslini is interesting. Just I would like to mention this, Mr. Gaslini was an industrialist. He had a daughter, 11 years old, Giannina, who suffered from peritonitis and in 1917 died of that. He was always feeling why my child could not survive. And in 1930, he started making a center. It took 6 years. People think that Gaslini Institute is a building, a double story with this. It is 73,000 square meters with 20 buildings connected in a slope coming from mountain to the sea, and it's one of the best centers, not only Italy, in Europe. In 1956, it was accredited like this JCI, and other centers, of course, in NIH, where Dr. the Daniel Kastner was there. Thank you very much. Now over to Dr. Kalpana Sengupta, the secretary of the club, to start the question and answer. Please.
Thank you, Dr. Saurabh. Thanks a lot, Professor Surjit Singh. We've heard this lecture before, but believe me, we didn't remember a thing. So this just goes to show that, like Dr. Sohrab said, that we will start diagnosing. But I want to start by asking you what really would be the prevalence of these disorders, in a general pediatric OPD. What would you think? How often are we likely to come across them?
No, these are definitely not very common conditions. And uh, as I said, we are only beginning to understand some of these disorders. And in our own clinic, I distinctly remember children whom we had initially diagnosed as polyarthritis or systemic JIA, treated them for these conditions. And it was only later we realized that what we were dealing with was, for instance, Blau syndrome. NOMID we have missed. So in a general pediatric OPD, no, they are not very common, but you would get alerted if a child is brought with periodicity of symptoms, that means periodic fever, joint pains, and the duration of complaints is significant, then you would begin to work up these conditions. And workup almost always would include genetic workup.
And that has been one of the questions asked by the audience as well. Is a genetic diagnosis always required? And you made it amply clear that it is. And since we are going to diagnose them, definitely these are rare disorders and require long-term treatment, specialized treatment. Now, what I would like to know is that what genetic test should one offer? There are such diverse disorders. So, how does one go about, finding out which genetic test is to be ordered in a particular case?
Uh, it depends on where one is practicing. In India, for instance, now genetic tests are very easily available, and they are available in the government setup and also available in commercial laboratories. So if the diagnosis is an autoinflammatory disorder, you can do an autoinflammatory panel. But increasingly, what you would do is you would order a whole exome sequencing, because the cost difference between an autoinflammatory panel and whole exome sequencing would not be too much. To give a rough example, the whole exome sequencing in India can be done for somewhere between 10 to 15,000 rupees. So which is not very expensive. So which comes to uh, for people who are not conversant with the Indian rupee, this would be something like 150 to $200. So which is affordable. And increasingly now, our threshold for these tests has gone down, and the tests are becoming much less and less expensive now with the passage of time. And once you suspect these conditions, you get a whole exome done, and that is how you diagnose them.
So that's good to know that these tests are affordable and one can conclusively diagnose these cases. There's a question by Dr. or rather a comment by Dr. Ravs Al Newman, who says that he has a 12-year-old patient with MNF who was poorly responsive to colchicine and proved by genetics. Also, he had developed bilateral congenital glaucoma and last year developed insulinoma with severe attacks of hypoglycemia. Child was operated upon with partial improvement. Unfortunately, anakinra is not available and they are using monthly infliximab with partial response for 1 to 2 weeks. So, what would your comment be regarding this combination and treatment?
Yeah, if it is FMF, most children do respond to colchicine, but colchicine has several side effects and some children can't tolerate it. So in that setup, uh, people have used anakinra. So this is one disorder about which we do not have much experience. We only have a couple of patients with FMF, but I know that anakinra has been tried in this condition.
So there was another question with regards to familial Mediterranean fever, saying that if we don't have the genetic diagnosis, can we still start colchicine and use it as a therapeutic test?
It all depends on where one is practicing. If the child is severely symptomatic and genetic tests are either not available or completely unaffordable, then yes, I guess one has to take a difficult choice, and trial can be given. But ideally, since the treatment has to be so long, one must confirm the diagnosis before uh, uh, you know starting treatment. So ever since anakinra became available in India, uh, the life of these patients has improved significantly. So till around 4 years ago, even in India, it was very difficult to get anakinra. Anakinra is made by a Swedish manufacturer, and this is the only manufacturer in the world. And there are many countries where anakinra is still not available. So that is a problem with anakinra. But since it has become available, and more importantly, since now it is being given free of cost at several government facilities in our country. So the government has established several centers where these patients can be registered and can get anakinra. Life has become much easier for such families.
And are there any specific precautions we have to take when we are using anakinra for the
Dr. Kalpana, your voice is feeble.
No, I
No,
was
not
asking
really.
whether
It is usually tolerated. It is usually well tolerated.
usually well tolerated.
Yeah.
Dr. Saurabh, I had just asked about the tolerability of anakinra since we are using it for a long period.
Yes.
Yeah.
The more side effects are seen with TNF inhibitors, especially when we were using infliximab, because allergic reactions with infliximab can be very significant. You can get anaphylactic reactions with infliximab, but these are generally not seen with other biologics. So they are much better tolerated. But before you start TNF alpha inhibitors, of course, it is a routine to work up for tuberculosis, and you have to rule out tuberculosis before you start TNF alpha therapy.
So I would like to ask you, doctor, about your cases. The first case where polyarthritis nodosa was diagnosed in a girl, and her brother presented subsequently and was diagnosed as DADA. What was the follow up on that case? Did the brother develop similar symptoms or no?
No. The brother only had ocular symptoms,
Mm-hmm.
while his sister had severe abdominal complaints. So this is well known that with the same mutation, DADA2, the clinical phenotype can be rather different. So after these patients, we have started working up all our patients with polyarthritis nodosa for DADA2, because it is said that juvenile polyarthritis nodosa, you should screen for DADA2 before you give a label of idiopathic polyarthritis nodosa. So this is how new discoveries and new developments change your diagnosis and change your management. So we were sure when we had initially diagnosed that patient, we were sure that we were dealing with polyarthritis nodosa, because that child fulfilled the diagnostic criteria for PAN. But it was only much later we realized that this was not classic PAN, but DADA2.
And in the cases where we have fever, we have serositis, steroids are given in both the autoimmune and the autoinflammatory, some of them. I mean, fever with serositis, we could think of SME like conditions. So, how do we actually differentiate it? Unless, other than genetic tests, is there
No,
anything else that would
if you're thinking of a disorder like lupus, that will be very easy to differentiate because you would
diagnose?
get the anti-nuclear antibody test, you would do the
Antibody?
anti-dsDNA test, and the clinical features also will give you some evidence usually. The rash may be there, the
Right.
lupus rash may be there, oral ulcers may be there. So if
Mhm.
none of these findings are there, then you begin to think, and the symptoms are recurrent, then you begin to think of autoinflammatory disorders. So the full spectrum of these disorders, I think, is still emerging. We know very little about these conditions, but what we realize is that for many of these conditions, we are completely ignorant, and
Mhm.
and you can be very wrong at times while managing these patients. So genetic diagnosis in India, uh, uh, they started getting being done more frequently only in the last maybe 8 years or so. So prior to 2015, we were not getting many genetic diagnoses done because the tests were not easily available. We were sending these samples to some of our colleagues in Japan, Hong Kong to get the diagnosis made. But
Mhm.
over the last few years now, I think India has become you know, the testing center of this part of the world. And
Mhm.
these laboratories get samples from many countries in the Southeast Asia region as well. So, and with 150 to $200, it's not a very expensive test.
Um, there is a question from Dr. Joshi who would like to know what is the reason for such a typical cyclical nature of fever in these children?
I
Any-
really don't know. I am no, I won't know the answer. I think it is
Mhm.
just a biological phenomenon which is associated with these disorders.
Mhm.
No, I won't know why it is so periodic.
Okay.
But what
And
is known is that the periodicity breeds true. That in a given patient, suppose the child has symptoms after every 3 weeks, so these children will continue to have symptoms every 3 weeks for reasons I think that are not very clear. Incidentally, Dr. Dan Kastner and both Dr. Dan Kastner and Dr. Efila Goldmansky have been to India on more than one occasion. And Dr. Dan Kastner will again be coming to India in February
Mhm.
at the annual conference of the Indian Society for Primary Immune Deficiency, ISPID in Lucknow. So he will be there in Lucknow in February.
good to know those who are interested and would like to meet the pioneers can definitely attend this conference. Uh, there is a question, the doctor's not written the name. What level of ESR should be considered alarming for autoimmune or autoinflammatory disease?
There is no absolute cutoff, but I think anything above 30, persistently above 30, um, would become worrisome.
About 30. Okay. Dr. Vivek Maheshwari wants to know how can we suspect macrophage activation syndrome in lupus or arthritis difference clinically? I am
Well,
not sure. Yeah.
macrophage activation syndrome is often a clinical suspicion.
Mhm.
So, um, in a patient with a rheumatological disorder, if suppose the fever suddenly becomes spiking, there is no evidence of infection, the child becomes very unwell and he may deteriorate over hours. The platelets start sinking, the neutrophil count starts sinking, LDH goes up, triglycerides go up. That is a time to intervene. We quite often intervene even without a bone marrow. If you can get evidence of hemophagocytosis on marrow, uh, that is all right. But you don't wait for the marrow results before you intervene. So high CRP, falling ESR, these are the typical features of macrophage activation syndrome. It can be associated with several rheumatological disorders, most common being systemic JIA, but you can see it in lupus, you can see it in juvenile dermatomyositis, you can see it in Kawasaki disease. So macrophage activation syndrome is a rheumatological emergency, and if you pick it up, the results can be very gratifying. The pulse methylprednisolone is often life-saving.
Dr. Sammy George wants to know what about Behcet syndrome?
Behcet syndrome can have, again, very varied clinical presentations. You can have incomplete Behcets, you can have complete Behcets, you can have predominantly eye involvement, you can have predominantly genital involvement. Whatever Behcets we have seen, we don't see too much of Behcets. We have seen predominantly eye involvement Behcets, in which there is very troublesome posterior uveitis, and some children, only some children have had genital involvement.
No, this one I'll interrupt now. Dr. Dan is working now mostly on this Beche syndrome, the genetic problems of that. And I think the Turkish who first described this,
Yes, yes,
Dr. Beche.
yes, yes.
One doctor wants to know that if I have child with recurrent fevers, how long should I wait before suspecting an autoinflammatory disorder?
Well, you would obviously first rule out the common causes, and that includes infections. And if a couple of months have gone by and there is typical periodicity, then yes, you are within your rights to suspect an autoinflammatory disorder, especially if there is multi-system involvement.
Right. There's a comment from Dr. Chidambra Harikumar, who has written that in his general peds clinic, one per week only, I've seen multiple cases of FMF and PFAPA and a couple of DADA too. Also, 2 cases of NOMAD in my neonatal practice, so not very rare. That's a bit surprising because we're running general OPD every day. We don't know whether the incidence is less in this part of the world, but or we are missing it because tip of the iceberg. We don't know. A lot of cases might be missed.
No, yeah, till Dr. Kalpana is searching. I was reading the question of difference between autoimmunity and autoinflammatory. They say this is the same spectrum. One end is autoimmunity, other end is anti-inflammatory. These are the same spectrum. One is in one end, one is that. I mean, they are not differentiating. They said these are the same thing in one spectrum, one is in other side, how the thing progress. What is your opinion regarding this?
Yes, that is absolutely correct. That is absolutely correct.
So, going further, doctor, about the case of Dira, the first case that you showed, got anakinra arranged and is doing so well. What would the normal course be in the absence of any treatment?
Oh, these children would continue to, suffer and maybe ultimately develop amyloidosis.
So most of these autoinflammatory diseases would develop amyloidosis.
Yes, yes, many of them will develop amyloidosis and die of amyloidosis.
In the case of the steroid-resistant nephrotic syndrome was biopsied, and on biopsy there was amyloidosis, hence the genetic testing was done.
Yes, 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 yeah.
So yeah, I think there are a couple of personal questions. I would request those doctors to contact Professor Surjit Singh directly to get their personal cases solved and answered. Frankly, I feel that even though we are talking from UAE, I feel we are sitting in a very remote village compared to your state of the art center at PGI Chandigarh, India. Proud of it. Just like you collaborated with the other centers abroad, I think it's now probably for us to request help from you as and when we happen to suspect these cases, not only to diagnose but to get them, confirmed and treated. So
Absolutely.
that's a request, Dr. Saurabh. I think from the audience, we have finished most of the questions that they have asked.
Some questions were sent.
Yeah.
One was,
Is
I
there
think,
a
about is it a
lifelong-
lifelong, Dr. Sujit Singh, or I mean, lifelong they have been treated? Is there any, I mean, permanent cure, or how long they should take treatment?
No treatment. You know, a disorder like PFAPA, it is said that it is self-limiting. After a few years, the episodes disappear on their own. Or after tonsillectomy, they disappear sometimes. But other disorders, unfortunately, treatment has to be lifelong. But we must remember that the total world experience for these conditions is not more than 10, 15 years for many of these disorders. So it is not always very easy to convince the parents to take these drugs because these are expensive. But for most of these conditions, treatment has to be lifelong.
Another question about the use of steroids, because in some cases, I mean, of course, it doesn't come periodically like mononucleosis. When you give a steroid as if, I mean, water on fire. Or in other cases, do you think, I mean, giving a steroid will not mask other things? I mean,
Well,
empirically, because if you don't have facility and give steroids,
yes, if you don't have facilities, you can, you have to use some symptomatic treatment, and steroids would be the safest symptomatic treatment. But if the symptoms are persistent, then I guess one has no choice but to send the blood and get the genetic tests done. Short of that, there is only so much that you can do based on clinical assessment.
yes, doctor.
Yeah, there was a question that is there any autoinflammatory disorder without fever? And I think you have
Yeah,
shown the
yeah,
categorization.
yeah.
Mm. So once we follow that, it should be okay. And are these curable? Are these conditions curable?
No, not really. They are treatable, but not curable in its simplest terminology, because they would stay. These disorders are there to stay.
And what actually triggers autoinflammatory diseases?
Look, Sujit, what about gene therapy? No, they have found that the problem is in the genetic. So if gene replacement, they go and take the defective gene, or gene therapy, what is the role of gene therapy for future?
I don't think gene therapy has been tried yet in these conditions. Gene therapy has been tried in some of the immune deficiency disorders. So, for instance, in ADA deficient SCID, in chronic granulomatous disease, Viscott-Aldrich syndrome. But to the best of my knowledge, gene therapy has not been so far been tried in autoinflammatory disorders.
So what was the follow-up in the case of Papa that you showed with those scary looking
No, we
ulcers?
were we were not able to treat that child at that
Hmm.
time. But if such a child comes again, yes, we may be in a position to offer better treatment.
So can we conclude by saying that if we see a child with rheumatological symptoms not fitting into any particular direct diagnosis, we should think of
Yes, especially
autoinflammatory
if there is multi-system involvement.
multisystem and
Yeah,
periodicity
yeah.
in some cases, as you mentioned. Um, right. We still feel like we are clutching at straws here because there are diverse group of diseases, disorders,
Yes,
And,
they are. They are. They are.
but at least you have shown us some very classical cases, and in our clinical practice, if we can at least start thinking about them, it would go a long way, I think, to diagnose them. Yes, Dr. Saurabh.
So I think it is late in India and very cold also. So we would like to keep Dr. Sridhar. Dr. Sridhar, thank you very much for this excellent talk. It was an eye-opener for all of us, really. Now we know
Thank
how
you.
many cases we must have missed. I would
Thank
like
you
to
very
thank
much.
all viewers staying till this time with us, Dr. Kalpana. We couldn't have Dr. Diari with us. I would like to thank Dr. Tawfiq for sponsoring. And I'm sure in future we'll disturb Dr. Sujit both for webinars, conferences, as well as sending the samples to PGI. I would like to say here, PGI is the biggest and most famous institute in India, and not only in India, Asia, and I can say in the world, one of the best centers. So, Dr. Sujit Singh, we are fortunate enough to have him here. Thank you very much.
Thank you.
I
Thank you
would
for
like
the
to thank all
invitation.
viewers also.
Thank you. Thank you.
Thank you.
Thank you and good night. Thank you very much.
Thank you.
And our winner was Dr. Amit Soyal. He just wrote Daniel, but we accept. We accept.
Daniel from
Dan
America. Dr.
Kastner
Daniel
was
from
the father of autoinflammatory disease. Thank you very much and good night.
Thank you. Thank you.
Thank
No,
you.
thank you, Dr.